Welcome everybody. Welcome back, Clinical Problem Solver. So I'm Franco. I'm glad to be here at this Global VMR. So actually this time is my first time facilitating, so I hope I will do it well. And I'm glad to see everyone here. So for this kind of time, I'm going to pass the mic to some of the team members to introduce themselves. I think I can pass the mic to Baldi.
Thank you, Franco. Yes, I'm really excited to hear you facilitate today and to hear an amazing case. So yeah, I mean, if anyone has a case, please bring it to the table so that we can all discuss it. And yeah, I pass the mic to Gabriel.
Hello, everyone. My name is Gabriel. Very happy to be here today. It's very sunny here in Lima, Peru, and so excited for this case. And Franco being facilitating, I know it's gonna be awesome. I'll put Corey over Rafa.
Hi, everyone. My name is Rafael, and I'm a last year medical student from Brazil. Always a pleasure to be with you guys, and really excited to see how Franco will facilitate this session. He's an amazing person and probably a stellar educator in the future. Probably not, I'm sure of that. And I'm gonna pass the mic to, let me see, Marcelo.
Hi, everyone. I'm a doctor from Brazil. I'm really happy to be here, really excited to see the case and for Franco and everything. So I'm going to pass the mic to Thiago.
So hi, my name is Thiago. I'm from Brazil. It's a pleasure being here as always, and I'm looking forward to learning from Franco and all the crowd, and I'll pass it on to Hans.
Yeah, my name is Hans, and I'm just the same as you are. I'm looking forward to the case, and hopefully I'll have a case myself. I've been at a clinic here nearby for 2 weeks now, so I hopefully come across something interesting next time.
Please go next, NMK.
Good afternoon, everyone. I'm Anne-Marie, hospitalist. So happy to hear an amazing discussion. I know Franco is gonna just absolutely knock it out of the park. I think everyone's introduced themselves. And
I see Deborah and Shema.
Hi, I'm Shema, and it's a very pleasure to be here again at Global VMR.
Hello, everyone. I'm Deborah, and I'm excited. It was a really great week with a lot of amazing cases. So let's see what is coming.
Perfect.
And hi, I'm Catherine. I'm a third year medical student from Pennsylvania.
Great. So I'm so glad you can connect today, Catherine. Hope to see you so many times. So
Yeah.
I think we are looking for a case presenter. If someone has a case, we can kind of wait for a couple of minutes. Otherwise, I think Rafa has a backup case, right? Perfect. So, meanwhile, we wait for a case presenter. I don't know if you have the opportunity to saw yesterday VMR. So I want to kind of reflect on that. And Thiago made also an amazing Twitter post about it. So Thiago, could you explain us a little more about your Twitter post while we wait for a case presenter?
Hey, Franco. So yesterday I learned a lot from you. I had no idea prostate cancer could differentiate it into a NET neuroendocrine tumor. And I was glad to study it after, and I found many articles. So it happens. And I think it was a great moment for us to think about several learning points, endless learning points. Like it was a diarrhea for 2 months, and it turned out to be a VIP secreting tumor that differentiated from prostate cancer. And when do you think about a VIP secreting tumor? Never, because it's so rare. So it's less than 1 million, less than 1 case per million per year. But you know, there is the typical scenario, the typical clinical picture, and it was there, like watery diarrhea with hypokalemia. But even when you see it, you don't think about VIP because it's so rare. But the patient didn't improve with resuscitation, antibiotics, and everything was normal, ova, parasites. And then they could think about it, the VIP, and then VIP was high, then you have a diagnosis. It was a VIP secreting tumor. So the neuroendocrine tumors, they are so diverse, they can produce hormone or do not produce hormone. But after you know it's a VIP secreting tumor, you have to find it, to localize. And the most common site is the pancreas. And they realized the image, but the pancreas was normal, but there were liver images. So, whoa, you have a VIP, which is far from usual. And now you have an image that's far from usual for a VIP secreting tumor. And then they realized that actually it was the prostate cancer differentiated into a VIP secreting neuroendocrine tumor, a very rare case, but with endless learning points.
Amazing, amazing. So as Reza said, when Thiago speaks, you just listen, just poetry. So I think we can go up with the case, Rafa. Okay.
Awesome, awesome. We're just gonna ask for the crowd to keep their thoughts. Let's do this like an exercise. Should be fun. Vale, could you please share the screen?
Yes, I'm trying. Can you please let me know if it shows?
Yeah, it's starting to show.
But it's the whiteboard?
Yeah.
We can see it right now.
Yeah, it's ready now.
Thank
Okay,
you.
so I'm just gonna give the chief concern. This is a 29-year-old male that presented with chest pain.
Perfect. So that's a really good main chief complaint to develop some thoughts about it. So first of all, what I want to look for is that chest pain I usually divide it from 50 years older or less than 50 years. So when you think about chest pain in a 50-year-old person, you tend to go to more causes like more common causes like infarction or like a possible pneumonia or those sort of things. But when we see like this is a 29-year-old male with chest pain, we kind of broad of thinking process, because it is not normal for a 29-year-old man to have an infarction unless there are some underlying diseases that can cause this, like some thrombophilias or some sort of things. But nevertheless, we cannot just focus on the heart. We can just focus also in all the thorax, all the pulmonary problems, pneumonia, pulmonary embolism. And if we take a more anatomic approach, we can also present with the issues that involve the chest cavity itself, like some skin problems. There is also a good approach thinking about if there is some dermatologic concerns like herpes zoster, or even sometimes we don't overlook the psychiatric problems. Panic attacks can present with chest pain. So I will stop there and do some watching the chat. I have been seeing that maybe Hans, could you give us a little more about your thought process?
Yeah, I think we already got a good clue, and it was mentioned before, the 4 + 2 + 2. I was at first thinking a young guy and chest pain, more like trauma in the pneumothorax, which has been mentioned as well. And yeah, then we can just quickly go over the 4 + 2 + 2 because it's a good way of remembering what might be possible.
Amazing, Hans, amazing. Seima, can you go ahead?
Sure, about which point exactly?
About what you're thought
Yeah,
process.
okay, sure. When I was thinking about a young man with chest pain, especially if he is very slim, I would think of pneumothorax, and if this is an acute process. And for coronary aneurysm, I was thinking about any kind of vasculitis like panarteritis nodosa or maybe Kawasaki, but I think Kawasaki is more typical for like 10-year-old people. Also, myocarditis is like the most common case if we think of sudden cardiac death. Like, I don't know if he was in Latin America, and any kind of viral infection or Chagas can also cause myocarditis. And also for Fabry, as a lysosomal storage disease, it can cause a hypertrophy of the cardiac muscle. Yeah, and also we were thinking about hypertrophic obstructive cardiomyopathy. So I would think into these directions.
Perfect, perfect. Jasmiran, could you tell more about what your thought process so far is going on?
Hello, Franco. Hello, everyone. So I would say, first and foremost, the emergent causes that we need to rule out if a patient with chest pain comes to emergency. So that would be like angina, pulmonary embolism, and all these things that can mimic. So any kind of inflammation of the pericardium and aortic dissection, the rupture of any of the vessels in that chest thorax region, that can be emergent. So that will be the first train of thought. And secondly, a lot of people are already mentioned about the inflammation of the aortitis. And the reason they are mentioning it is because this patient is young. So a young patient most probably will be having something that is affecting the connective tissue, maybe some infection or an autoimmune inflammatory process, any kind of inflammatory process. It can be autoimmune or malignant. So definitely, as Shema also mentioned, any kind of vasculitis, Behçet's IgG4 disease, or last time we presented a case last Tuesday where doctor saying relapsing polychondritis that can affect aorta as well. And then there are the primary vasculitis causes like giant cell arteritis, Takayasu arteritis. They are known to cause inflammation of the major vessels. So all these vascular causes that has to be kept in mind because they can cause the inflammation of aorta, and this young patient might be having some autoimmune phenomena going on. Thank you.
Perfect, amazing. So I saw that Rafa just sharing your screen about the schema about the 4+2+2. So what I've noticed there that we see a lot of vessel disease or the heart disease, but Catherine has a good point regarding this patient and this age. So Catherine, could you please tell us a little more about your thought process about the cocaine?
Sure. I just know that cocaine is a pretty common presentation for chest pain in adults. It can lead to, it can cause vasoconstriction and ischemia of the heart. And then also another common presentation for young people with chest pain is like kind of new onset GERD, so reflux disease. So.
Perfect, amazing. It's kind of a good bridge between epidemiology and the presentation of this patient. I want to point out that one of our regulars attend, Dr. Ravi. What do you think about thinking outside the chest? What is your thinking about it?
Hello, can you hear me?
Yeah.
Oh, okay. My computer didn't work, so I had to switch to an iPad, so a different device. But yeah, and a very interesting complaint. And one of the most common complaints that you'll see in the emergency room is chest pain, just like abdominal pain, weakness, headache, and so on. So this is one of the diseases or presentations that you need to sort of start the diagnostic process. So this 4+2+2 is a brilliant way of thinking through. But then you also have to stop and start the therapeutic or investigative process. So right off the bat, get an EKG, get cardiac biomarkers. And while those things are being obtained, you do further investigation, which is your history and physical. So right now you have this young person with chest pain, and a couple of people alluded to, his chest pain. I think, Franco, you mentioned age category. So it's very unusual for a young person to manifest with the usual atherosclerotic cardiovascular disease. So a few things stick out. I did mention looking below the diaphragm. I had a patient that was given to me through the emergency room with chest pain, and actually had lab abnormalities. AST was elevated, ALT, bilirubin, there was leukocytosis. So that made me focus on the hepatobiliary area. And the patient actually had cholecystitis. So cholecystitis can actually radiate to the chest. And I asked the patient, where was your chest pain or where was your pain? It was in the chest, but the pathology was in the gallbladder. So definitely always look below the diaphragm for other issues, maybe hepatobiliary, maybe somebody mentions GERD may be causing an issue as well. So a couple of thoughts on one issue that has stood out to me is SCAD. It usually happens in young females. Another issue is MINOCA, so myocardial injury of non-coronary obstructive coronary artery etiology, means that there's no pathology in the coronary arteries, but you could have something like spontaneous lysis of a thrombus. You could have something like Prince-Meadows angina. You could have something like cocaine, energy drinks, or hyperadrenergic state. So a couple of things I just want to mention there. Yeah, thanks.
Amazing. Answering the question of Turan, correct me if I'm spelling your name wrong, sorry about that. Yeah, probably this is irritation of the diaphragm and can also irritate some the phrenic nerve and can also present with that presentation of chest pain outside, with the source being outside the chest. So I think we can move on to the next aliquot to figure out more clues about how to evolve over in this script. Go ahead, Rob.
Absolutely. Just want to say that it's an incredible discussion. Okay, so this patient started developing acute onset chest pain after 30 minutes of exercise in the gym. This patient says that it has never happened before. He describes the pain as crushing substernal chest pressure, lightheadedness, nausea and vomiting, and diaphoresis. And the pain persisted about 20 minutes. This patient works as a police officer and exercise 7 days a week without difficulty, and denies anabolic steroid use. On the review of systems, it's negative for fevers, chills, weight loss, cough, dyspnea, leg pain, and swelling. Oh, it's no fevers, chills, weight loss, cough, dyspnea, leg pain, and swelling. Yes, there is no mention of back pain. When it comes to the past medical history and past surgical history, it's non-contributory. Family history, this patient grandparents had MI in their 60s. And this patient also has a cousin with DVT during pregnancy, and a paternal aunt also with a DVT episode. When it comes to social history, this patient is non-smoker and denies ethanol use, illicit drug use, or vaping. He takes no medication and denies supplements or any other medications. And that's the end of the aliquot.
Perfect. Now we have tempo included to the chest pain. So we have to think about acute plus chest pain in a younger patient. And what immediately got my attention is that even though they don't seem to have like early onset family history of myocardial infarction, being that less than 50 age, we have some history of previous venous thrombosis. Although pregnancy can definitely increase the chances of getting a venous thrombosis, this can also be thinking about like put in our thought process in order to think about young patient acute chest pain with some kind of sort of previous history of thrombophilia. Something that I would be interested to know later on would be like if this patient is like his habit in order to think about Marfan's or some collagenopathies that can present with this kind of picture if there is if this patient is tall, so we can also figure it out there. But for me, and I think I can pass the mic to Gabriel. Gabriel, what makes you prioritize cardiovascular or pulmonary etiology? Why do you jump to that?
Yeah, sure, Franco. So the HPI was quite interesting for me because the acute chest pain started after doing exercise. So exercise translates into a hyperadrenergic response and also oxygen requirement of the cardiovascular and pulmonary system. So given that nature of the chest pain, I was thinking maybe if this could be a cardiovascular ischemia that was precipitated by the physical exam or a pulmonary embolism that due to the demand of oxygen, the tissue got ischemic and therefore the chest pain.
Perfect, amazing. I see that, Jorge, what do you mean about the question of pre-workout use? Could you explain us a little bit?
Oh yeah, sorry, I was a physician in the army and I have a lot of young kids, patients like coming with chest pain, and it was like secondary to the pre-workout. But he just said that no pre-workout use, so that's why I mentioned it.
Perfect, perfect. So yeah, that could be also an important topic in that kind of population. So, Jasmine, why do you are asking about how long did the pain persist? Could you expand a little bit about this question?
Oh, yes. So normally we used to read like more than 20 minutes. It points towards the MI. So as this patient, like whenever you used to read in the for the exams in the school, that the duration of the pain is very important. So 5 to less than 10 minutes. So it will be like towards the stable angina or unstable regarding whether the person is having the pain with exertion or not exertion. If with the exertion only, then it's unstable. Yeah, it's stable. And if it's at rest also, then it is unstable. And then to differentiate between unstable angina and the NSTEMI, which can have the same duration of pain, then we can go for the enzymes and other things. So definitely we used to read 5 to 20 minutes, more than 20 minutes. So duration of pain is also important if they can give the history. And
perfect.
Another thing that we used to read, that how important it is for the patient to undergo the percutaneous intervention. Like we used to read, if it is a facility that can give the PCA, it should be within the 90 minutes to the doorstep. And if it is not such facility, within 120 minutes. So definitely knowing the duration of the pain will make you better assess when the patient needs that immediate intervention, if it falls in that risk stratification for the intervention, I would say.
Amazing pearls, Jasmine, as always, amazing pearls. So now we'll pass the mic to Tiago, because there was a question about how can endocrine problems present with this chief complaint and this history. Tiago, could you explain to everyone?
Hey, Franco. Yes, I saw same question. And, for thyrotoxicosis, or I'll call thyrotoxicosis, but for thyroid hormone excess, it's usually very symptomatic, meaning the patient will present with tremors, palpitations, weight loss, anxiety. And sometimes there are fewer symptoms, but usually in older patients. So can a patient present this way and it be like thyrotoxicosis? Yes, it can, but it's unlikely. And the thyroid, when you have excess of hormone, then your systemic demand will be higher, meaning that you will require more from your heart. And also, as the heart rate is increased, the ventricle filling is lower, and it can precipitate ACS, acute coronary syndrome, in those who have predisposition. So for thyroid, I would say usually hyperthyroidism is very symptomatic, and hypothyroidism is mainly asymptomatic, but it depends on age. And the younger you are, the higher the risk of being very symptomatic.
Perfect, amazing, friend. Before passing to the next aliquot, I want to reflect on another things that I have been looking in the chat, that even though it's not common for a patient this age to have an acute myocardial infarction, we should always think about it. We cannot, this is something that falls into the category of never miss. And we should never miss something that could potentially disabilitate the patient or could potentially have fatal prognosis. So that is quite important. So I think I'm loving this discussion and we can continue, Rafa.
Sure. Going on to the physical exam, the vitals of this patient. The temperature was 97.6, the Fahrenheit, the heart rate 49, blood pressure on 128/83, and he's saturating 98% on room air. Generally speaking, this patient is in moderate distress, but his HEENT exam, pulmonary exam, abdominal exam were all within normal limits. When it comes to the cardiovascular exam, this patient is bradycardic, regular, no murmurs, no regurgitations, no gallops, and pulses is 2+ bilaterally. When it comes to the extremities, it's warm, no edema, and there is no bruising on skin. And I'm gonna just wait for the whiteboard before moving on to the labs. Pulmonary exam, it's normal. Abdominal exam, also normal. And yeah, extremity screen, no bruising, no edema, and it's warm. So yeah, it's 49, the heart rate. He's bradycardic. So moving on to the initial labs, the white blood count was 11.8. The differential is not available, and hemoglobin and platelets were within normal limits. The creatinine was 1.3, no known baseline. The BNP is normal. Troponin is less than 0.04. Total cholesterol is 181. LDL 113 LDL. And HDL 61. The hemoglobin A1C 5.2. And urine toxicology is negative. And that's the end of the aliquot.
Oh, that's what's quite a quote and give us some clues. So before passing the mic to Siram, who has an excellent level of bradycardia in this clinical picture, I want everyone to reflect about the program representation so far. If you can help and write it in the chat on the chat in order to have it. So go ahead, Siram.
Hey everyone. No, I just thought the bradycardia could be due to an RC obstruction. I know that with RC obstruction, you sometimes get sinus bradycardia. But correlating that with the troponin levels, it may not actually be an obstruction or an ACS. It could more or less be arrhythmias, as people have started mentioning in the chat. Yeah, that's all I was thinking. Thanks.
Perfect, amazing. So yeah, bradycardia is probably RCA if we are localizing to the cardiovascular to a cardiovascular problem. Dr. Ravi, you're asking for an EKG. Could you reflect a little bit about the cardiac enzymes, because they are between normal limits? Could you give us a little clue about that?
Yeah, I missed that part on the enzymes. Okay, the enzymes are normal, pro-BNP is normal. So that's kind of now introducing something interesting. Looking at the complaint, it's still chest pain. You know, there's no signs of inflammation that I see. White count, a little bit elevated, but in myocardial infarction, you could get some mild leukocytosis. I definitely still would like to get an EKG because during this diagnostic process, you can at least eliminate or get off the table a couple of these diagnoses, especially the life-threatening do not miss diagnosis. But a couple of thoughts with this. Bradycardia introduces an interesting a bit of news here. Bradycardia could be caused, like Kushala mentioned, just Imran, that there could be a RCA infarct or occlusion there. But occasionally, when you get a troponin, the initial troponin at the time of presentation could be normal. I've had many cases where patients can have chest pain and haven't infarcted the muscle or the myocardium, but are in the process of. So maybe they're having the prodrome of infarction, which is ischemic injury. So an EKG, at least if there's ST depressions in contiguous leads, so you want to look if it's the right coronary artery, you want to look V1 to V3. Usually there may be sort of like an inferior injury. And then the contiguous leads, you want to see opposite sort of findings in 2-3 AVF. So you want to see a pattern of injury. But what if this is something like pericarditis? Pericarditis, you may have diffuse ST elevations, ventricular aneurysm, diffuse ST elevation. So you want to look for a pattern of injury. So I think myocardial ischemia / injury is still in the running. A couple of people also discussed arrhythmias, but this is not a tachyarrhythmia. This is a patient has a bradycardia. So when you're dealing with WVW, you're dealing with Brugada syndrome, you're dealing with HOCM or QT prolongation, those tend to be tachyarrhythmias. But it's not uncommon for patients to present with palpitations and will misinterpret that as chest pain or something's bothering them in the chest. So that's what I had to say at this point.
Amazing, amazing. And I think Jorge has the point. Jorge, could you explain us a little more about the heart rate of this patient?
So low heart rate, yeah, is concerning, but at the same time, he's only 29, and it seems like he's police. So I bet he's really, really fit. So his heart rate, he can live there. Maybe that's the normal for him. Why? Maybe it's not normal for everyone else, but for him, he might be okay.
Perfect. Yeah.
Franco, I had one more thing to say. When the first thing I usually do clinically, if I see somebody with his heart rate, and you're absolutely right, athletes can have a slower or lower heart rate. 49 though is excessive. I usually will look for somebody in the 50s. I would get them up and walk them. When you walk them, they should be able to accelerate their heart rate. Then at that point, you know, they don't need a pacemaker. They don't have any problems with their S8 or their sinus node. But if somebody gets up and walks and they can't increase their heart rate, as you increase muscle demand, you need more blood flow to the tissues to provide oxygenation for energy production. You have an issue of chronotropic incompetency. And at that point, you'd probably call EP for evaluation for a pacemaker. So that could be a maneuver that you could do at the bedside with a patient like this. But you're absolutely right. In a young person that's an athlete, they tend to have low heart rates. Although 49 is one of the lowest one I've seen. If I'm gonna label this as somebody who's an athlete.
Perfect. And before going to the next article, I want to reflect a little about if this is going to be a RCA, it's going to be a volume issue with this patient. So this patient will be volume dependent if there is an infarction. So I will definitely look out of any changes in the blood pressure later on. And also reflecting on the creatinine of 1.3, this could point out that this patient can, without a baseline, I don't know if this can prioritize later on if we have more clues about this in the follow-up of this patient regarding his condition that is making him getting acute infarction. So I think we can have the next article, Rafa.
Yeah, sure. I just wanted to say that you guys are absolutely right. So the first aliquot showed that the EKG showed a sinus bradycardia, but no ST changes. The chest X-ray was clear, and this patient went CT-PE, and it was negative for PE, pulmonary embolism. There was some repeated labs for the ongoing chest pain, and the troponin was elevated this time. It was 12.3. And the new EKG showed ST elevation in leads 1 from V1 to V5. Yeah, I'm gonna give just one more aliquot. This patient underwent left heart catheterization. Oh no, if I say that, I'm gonna spoil the EKG. Please go ahead.
No worries. So let's see. Now we have there was some movement of the enzymes, so this is definitely a acute myocardial infarction. But regarding this patient at that age, I will point out, someone in the chat point out that sometimes there is some anatomical defects that are congenital, some bridges between that the coronary artery goes below the muscle, and when there is some insertion, the muscle contracts and actually can elevate enzymes and can have this clinical picture. And definitely with the history of previous DVTs, it's absolutely not crazy to think about any thrombophilus being a factor 5 laden, one of the most common. I will definitely look for it. Does anyone has another thing to do follow up with this next aliquot, or we can just go ahead? I think I will look in the chat for a minute. Jorge, why do you are asking about changes on the PR interval?
Just asking, acute pericarditis, I think, if I remember, you can see that down slope of the PR interval. If it's like acute pericarditis, that's why.
Perfect, amazing. So I think before revealing this final diagnosis, I can ask some summary of this case so far. So maybe Vale can do a sum up in Spanish, because this is Global VMR, Marcela in Portuguese, and maybe Seima can have this summary in German. So go ahead, Vale.
Oh, Franco, actually, I don't know if Deborah sent me her program representation in Spanish.
Oh,
so.
perfect. Go, Deborah. We can hear you.
I have to say in Spanish, sorry, I kind of missed.
Yeah, if you can. If no, there's no problem.
No, sí, bueno, un hombre 29 años con dolor en el pecho de 30 minutos después del gimnasio. Posee una frecuencia cardíaca de 49 batimentos por minuto, un SG que presenta una bradicardia sinusal y elevación del segmento ST.
Perfect, amazing. So maybe we can follow up with the Portuguese. Marcela?
Sure. Homem de 29 anos, sem comorbidades prévias, apresenta-se com dor torácica substernal, impressão relacionada ao exercício físico e bradicardia ao exame físico. Yeah.
Perfect. So Seima, can you enlighten us with some German, please?
Sure. Wir haben einen Patienten mit einer akuten belastungsassoziierten Thoraxschmerz, Substernal, B-Symptomatik, Dyspnoe und periphere Ödeme werden verneint, und im EKG sieht man momentan ST-Hebungen von V1 bis V5 und der Patient ist bradykard.
Amazing. So I think this is the first time we have a program representation in German in Global VMR. If I need to be corrected, Rafa just told me. So after that amazing summary, we can go ahead with the final diagnosis, Rafa?
Actually, I am not, this is not going to reveal the final diagnosis. I was actually hiding a procedure, just not to spoil the EKG. So this patient underwent left heart catheterization, and it showed a thrombus originating the distal left main and extending to the proximal left anterior descending arteries, leading to 90% of stenosis. This could be thought about because of the EKG that showed ST elevation from V1 to V5. So you know you're dealing with anterior wall myocardial infarction. So you have to remember to think about the left anterior descending artery. And the left circumflex and RCA were angiographically normal. And this patient underwent transesophageal echocardiogram, and ejection fraction was 59%. There was an apical cap. The apical cap is akinetic. The right ventricle was normal in size and function. And the anterior septum, apical lateral segment, apical anterior segment, and apical inferior segment are mildly hypokinetic. And there's just one more aliquot that will reveal the final diagnosis.
Well, there is a thromby there and on a 29-year-old male with chest pain. So we're definitely looking for some weird cases of having like a thrombophilia or something that predisposes this patient to getting a thromby. So definitely we're looking for a factor 5, antithrombin 3 on the coagulopathies panel. Also, I want to like reflect on Dr. Ravi about apex is likely hibernating. Could you explain a little more about it?
Yeah, with the degree of injury that you have there, like Rafa mentioned, the EKG is diffuse LAD territory. And the clot is quite extensive. I think Kushal mentioned Takotsubo. This kind of does look like a Takotsubo, but there is a clot in Takotsubo. Is stress-related cardiomyopathy, but this is due to injury from the clot. So the apex, likely because of lack of blood flow, the myocardium may not be injured, but it may be hibernating. So what you anticipate is down the road as you reperfuse the area. There is one thing that can happen, reperfusion injury, but that's where free radical formation can happen, and then that can extend the area of injury. But when you remove the clot, that myocardium will have reestablishment of blood supply, and there could be an improvement in the pump capability of the apex or the motion of the apex.
Amazing. And Tiago, do you have some insight about how the lipid profile, right? Could you explain a little bit?
Yeah, so just to be sure, it looks like the thrombus is inside the coronary, right? So it's an infarction. Am I correct? Okay, so I will look to his cholesterol levels. It's expected that cholesterol levels, they decrease after MI, so be aware. But we have to think about esoteric causes because it's not, it's very common to have cardiovascular disease, but not at this age. And familial dyslipidemia, especially if you have both genes affected, it's a very important cause for precocious MI.
Perfect. So we need to have like a complete lipid panel, some thrombophilia panel, and also, although weird with this presentation, another thing, so thinking about antiphospholipid syndrome, although there is no many clues about this. I think we can just give us the final aliquot, Rafa.
Yeah, amazing. You guys are spot on. There was made a thrombophilia workup and all were within normal limits except for factor 5 Leiden, which was homozygous positive for mutation. This patient was then diagnosed with ACS, and he was started on GAPT with ASA anticoagulant, and the cause of the acute coronary syndrome was thought to be due to his homozygous factor 5 Leiden mutation that led to an acute thrombus in his coronaries in the absence of other atherosclerotic risk factors or plaque noted on LHC. So thank you, everyone.
Perfect. I love the discussion and how we are getting this diagnosis. So we have already done the program representation, and I think we can pass the mic to Gabriel to do the amazing teaching point.
Hello, everyone. Gabriel again. Thank you very much for the opportunity of doing the teaching points today. So to start, first we were approaching chest pain. And the first step in a patient that presents with chest pain in the emergency room is to rule out emergent causes. And we can use a 4+2+2 mnemonic to never miss these conditions. So for the cardiac system, we have acute coronary syndrome, Takotsubo cardiomyopathy, aortic dissection, tamponade, and for the pulmonary system, we have pulmonary embolism, pneumothorax, and the two others are esophageal rupture and impactation. And then if all this workup is negative and also the clinical presentation is not typical to the other conditions, we can move on to another causes and we can use the anatomical approach. And I hyperlinked the schema, the amazing schema of chest pain in the Clinical Problem Solvers website. So then with the HPI and the labs and the physical exam, we were collecting clues. And one important clue was that the chest pain first was acute in nature and after exercise. And exercise translates into a hyperadrenergic response and the body needs oxygen. So we can link that to if maybe this is a condition related to a ischemic process, or if this could be a cardiovascular congenital abnormality, or we can think also in some endocrinologic etiologies such as pheochromocytoma, although it's rare. In the physical exam, the patient presented with bradycardia, so we can localize if maybe this condition of chest pain is into the cardiovascular system. We were thinking about if this could be a RCI obstruction, or if the patient presents with any arrhythmias that requires doing AKG. So also one clinical pair that Dr. Ravi taught us was we can perform the walking test. And if the heart rate increase, maybe likely this is a physiological response and not a pathological because the patient can compensate. Then with the AKG, we were finishing our puzzle, and with all the exams, we found a thrombus in the anterior descending arteries plus hypokinetic apex compatible with myocardial infarction. So what conditions can cause a precocious myocardial infarction? We were thinking into a congenital dyslipidemias and a hypercoagulable state. So then the final diagnosis was factor-laden hypercoagulation. And thank you very much, guys. This was an awesome case.
Perfect. Before saying goodbye, I think Dr. Ravi has one more amazing teaching point to share with everyone. Dr. Ravi?
Yeah, just one point regarding your approach to chest pain in a young patient. So if you look at the literature, a lot of us are very interested in improving our diagnostic process. At least when you have a patient, like I mentioned, chest pain is one of the most common complaints that you'll see when you're in medical training here, especially in the United States. We do have a lot of bias when dealing with patients, especially young patients with chest pain. So we got to be very careful. Any young patient can have coronary artery disease. I mentioned studies. It was very interesting in the US medical history. Back in the Vietnam War, the average age of a soldier that fought in the Vietnam War was 19. So when they performed autopsies, they saw the beginning of coronary artery disease. So there is, like Franco mentioned, Thiago had mentioned, that there can be hyperlipidemia and other things, Western diet, smoking. They also promoted smoking in the army as well. So a lot of factors can weigh in on premature coronary artery disease, but younger patients can have the beginning of this. But just keep in mind, young people, there's bias against young people, there's bias against also women, young women presenting with chest pain. Something like SCAD can happen. Definitely take their complaint in mind. And you'll see stories, I've read different cases where patients were turned away from the emergency room because they're like, you're very young or you're an athlete, you could not have coronary artery disease. So they get discharged from the emergency room and come back with a devastating myocardial injury. So just keep that in mind. It's a great teaching case. There were so many great points on this. You did a fantastic job, Franco. Thank you for presenting this case, Rafa.
Thank you, everyone. I really enjoyed Global VMR. So I think we can say goodbye now.
Bye.
Bye, everybody.
Bye.